Did you know that lumbar disc herniations are a very common thing that we see in the physical therapy clinic? And a lot of them don't require surgery, which is often a misconception. We are going to show you and talk to you extensively about understanding your back and disc herniations in more detail. And at the end, we're going to show you our top 2 stretches. So wait till the end. Top 2 stretches that we give out routinely in the clinic to help a lot of people with this type of problem. My name is Tom Willman from Apex Orthopedic Rehabilitation in Wyckoff, New Jersey. Please, if you really want to see future videos, subscribe and hit our notifications, and you'll find out about other topics that we cover besides disc herniations, which you're going to learn about today. What we just reviewed recently is a review of the literature, and that just means they're trying to figure out what works best. Actually, 2024, and they looked at 3 major things made a difference for people with disc herniations to treat them without surgery. 1 was using the McKenzie Method, 2 was a general exercise program, and 3 was manipulations and mobilizations. And those are kind of special type of stretches, and some of those are actually used in the McKenzie Method anyway. But those are our 3 areas that we're going to cover. You have your L4, L5. This little piece, this little area right here is the disc in between these 2 bones here called the vertebrae of the lower back. And these 2 areas right here are disc. We have discs throughout the spine, actually, and it basically acts like a shock absorber and provides some stability to the spine, okay? As we move and bend and all that, it'll move and it kind of acts like almost like a ball bearing of sort in guiding motion, and it's very, very integral to movement. But it does break down and wear out and have problems in this area where they call them, and that's where our location of our herniations are. So disc herniations basically are made up, if you did a cross section like you'll see on this diagram, they have the outer annulus fibrosus, which is kind of like rings of tissue that kind of hold the center, which is the nucleus pulposus, which is kind of, some people refer to it as like crab meat or the inside of like a jelly donut. It's a little different consistency. The nucleus is actually what actually displaces or shifts that causes a herniation, depending on the type of herniation. But that's generally the anatomy. And the outer 1/3 of this disc, which isn't shown here, the inner portion of the disc doesn't have a nerve supply, but the outer portion is innervated by the sinovertebral nerve. So the idea is sometimes we don't feel it until this material on the inside, that jelly donut or nucleus pulposus, actually pushes out and eventually hits the nerves on the outer rings of this disc. So when this herniated material, that nucleus pulposus that we talked about in the anatomy, when that comes out, most times, so this is the front of your body, that's me here, this is my back, and this is about where my waist is, or most of my belt, okay? So the most common areas are the L4, L5, this disc right here, or the L5, S1 disc, okay? So where the disc material typically goes is to the rear, so this is a side view going this way or off on an angle. The reason why this is significant, especially when it's off, is that, and you can see right here this little red material, this is depicting a herniation that's actually coming out. It's not contained within the disc, and it actually hits this little yellow appearance is a nerve, and these nerves essentially go down to your leg and provide sensation. They also help with muscle contraction. They call motor. They can also carry a pain stimulus. So when the idea is that the disc can physically hit that nerve, and that's when we start getting leg pain. If it doesn't hit the nerve, you can still get essential low back pain and some referral down into the leg. But you especially if you have pain below the knee and you have a herniation, you may feel sensation below the knee into the foot area, especially in the lower lumbar area. Okay, so the reason why these are significant is where the disc comes in and essentially makes it little pressure. It pinches that nerve as it's exiting the spine. It can also pinch the spinal cord, which you can't see right here, but most commonly it'll hit this little yellow appearance, which is the nerve. So what causes a lumbar disc herniation? Some of it is just more common as we age. Between the 30 and 50 years of age, that's when you see more of our herniations. That's when we really see those changes occurring. And we have it, believe it or not, less so after that age 50. You still can have it, but you generally don't have it, it's not as common. The next one could be a herniation can occur due to a trauma or injury. That can be a motor vehicle accident, it can be a fall from a ladder, it can be anything that was a very significant moment where you all of a sudden put a great deal of pressure onto the spinal components, especially very fast. Like I said, car accident, sports injury where you have a collision type thing, and then you can develop a real spontaneous herniation. You can see certain herniations in repetitive activity or sustained positions. You can see it in truck drivers where they're in a very sustained position for a long period of time. They're really not moving a lot. That and also sustained activities, especially when you're dealing with higher loads, more physical profession, laborers, people like that, will have a higher incidence of disc herniation in that population. Or it could be your parents. It could be genetics. It could be the fact that you just have a predisposition to certain types of injuries, whether it be conditions or injuries. Disc herniations are the same thing. It can be related to just your family history. It could be that you also have a history of connective tissue, weaker connective tissue, so you're more predisposed to disc herniations, but also other types of soft tissue injuries, whether it be ligamentous injuries, dislocations, other things like that. You are going to be more predisposed to disc herniations just because of that fact alone. A history of smoking is also something that can make you more predisposed to disc herniations as well. There's a small vessel circulation to the disc that, when affected, can make it more predisposed to injury and also making it more difficult to heal. In fact, some surgeons will require that their patients that are going in for spinal surgery, especially anything that involves the disc, that they stop smoking prior to the surgery because the outcomes aren't as good, but there's also a risk factor going into it. So a very interesting thing in medicine, they call the natural history of disc herniations, and this means like if we just left it alone and these patients that have disc herniations didn't receive any treatment whatsoever, a lot of them get better with just time. And we're saying no medical treatment, no anti-inflammatories, injections, or surgery. They just get better with the passage of time. So within 6 to 12 weeks, or about 3 months, most of them, the symptoms are pretty much controlled and they're without symptoms at that point. And around 3 months, they said in the Journal of Spine, 60% resolve completely. They completely have no symptoms at all. And around 6 to 12 months, 70 to 80% of the people actually resolve, and they have no problems at all at that point. So a lot of them take care of themselves without any formal intervention. So that's the good news about these, even if you've been diagnosed. So like we said, a lot of these resolve with a little bit of time and a little bit of attention. What I will say is that a lot of folks still have some residual loss of motion, some weakness, and I think that's one of the reasons why it really predisposes them for having a second episode. So if you had a first episode of, let's say, sciatica, disc herniation, lower back pain, you are actually more predisposed to having a worse episode the next time it comes in. So it resolves, but you actually are at more risk for having it happening again. That's why I really think some education on things to do, things not to do, and kind of a proactive plan is really helpful, even if you've had most of your symptoms resolve and you're pretty mobile and get back to what you want. So there's different types of herniations, okay? So we're going to talk about the 3 types, okay? The first thing we're going to talk about is contained herniations. So the contained herniation basically is, if you looked at that disc that we talked about earlier, so you have let's say we take a little, like a circle here, you have those rings that we're talking about called the annulus fibrosus, and you have the nucleus, the center of that jelly donut. What happens is, in a contained herniation, basically the material in the center gets pushed against those outer rings, it kind of breaks apart through some of those outer rings, but it never breaks through outside the final ring. Basically, it still is contained within those rings, but it's starting to move out a little bit. It's not its normal anatomical location, and that's considered like a bulging disc. Sometimes you'll even see a decreased height of the disc, and they may even appear a little blackened on an MRI. Okay, you'll see some height differences and all that, and it's not normal. And you can still have some, mild to moderate pain, with that type of herniation, especially as it pushes out into the area where it has, it actually has a nerve supply, so it'll generate pain without hitting those big nerves that come down in your leg. Actually, the small nerves in the disc can generate a lot of central lower back pain and sometimes a little pain down into the leg and thigh. Okay, so consider that's a contained herniation, and that's more what we call our bulging disc or protrusion. That's another term you may hear that's talked about during this particular group of herniations. Second category is non-contained herniations. Okay, that's something that we'll refer to as an extrusion. Okay, well that fancy term, it's one way of describing it is. So now that disc material is actually outside of the rings. Okay, we showed earlier, so that little red spot on the outside of the disc in the early part of the video. So it actually gets out and breaks through the outer wall, we'll call it the fort, let's call it that. Gets outside the outer wall, and that at that point it actually can start affecting not just the small nerves of the disc, but also can affect those large nerves that go down our leg and give us tingling, numbness. We can even get some weakness down the leg. from this extrusion. We can even get a little bit of impingement on the spinal cord. Okay, so it's another significant degree up and something that we have to, it's just another level, and that's the non-contained herniation. The last one, last herniation, the third group, is a sequestered herniation. So you actually have the disc and the inner nucleus, a fragment of it actually detaches from the disc. So it's no longer attached. The extrusion, it's still it's attached. It's outside the walls of the disc and all that. But this one is actually detached. It can float around. It can cause some excruciating pain. They really are a big problem. But interesting, if you get past a year, those can absorb and basically not be there on a subsequent, let's say you do an MRI in a year. So one of the main approaches in addressing any kind of person that's got a lumbar disc herniation, depending on the type, is a round of physical therapy. Okay, and in that, within physical therapy, is a few things that how we approach this treatment is McKenzie Method, a particular way of moving the spine, which we'll explain in detail. The other one is doing some kind of form of core strengthening or trunk strengthening. Okay. The other one is manual therapy, which would be a form of stretching the spine specifically, mobilization, and what they call manipulation. And the last is nerve gliding exercises. Those are some of the main ones that they've identified that have some help during this period of time for short and long-term improvements with people with disc herniations. So the first approach is the McKenzie Method. It's been studied, probably the most studied method out there as far as treatment of various spinal, and actually most people don't know is other joint conditions, shoulder, knee, hip. There's other conditions the McKenzie Method does. And what we look for in the McKenzie Method is the person's being taken through an evaluation for various movements to see if we can have a reduction in pain and then also an improvement in function based upon a certain movement. Generally, at the end of an evaluation using the McKenzie Method, you're looking at 1 or 2 exercises that the patient will take home and work on. We have a couple of videos you see in our description that talks about the McKenzie Method in more detail, and also we have a couple that talk about some of our top McKenzie exercises that we give out in the clinic. So you could see that at the end of this video as well, at the very end, or you could see it in our description. But check those out, and it'll give a little bit more detail into exactly what that means and what the method is about. There's been some evidence that core and stabilization exercises have some sort of benefit. I will say that these core exercises are supposed to create some stability around the spine. Anytime there's a trauma or any kind of inflammation or irritation or pain response in an area, it can cause some atrophy and weakening of the tissues and the musculature around that area. And the idea is that we can get that a little bit more strength, we can get the person a little bit more mobile, they can become more active, they can be more, get past this period of disability, and also in some cases actually drop down their pain levels as well. The core strengthening, there's some classic ones that we're going to show that you'll see. Some of the things are called our trunk stabilization and also hip strengthening. All kind of try and address that and get a lot of it is comprised of isometric exercises where there's no movement of the spine, and we're just trying to kind of stabilize and get that spine more resilient for various activities of daily living. So keep that in mind. All these exercises should be relatively pain-free. They should be a little discomfort when you're doing these, but they shouldn't ever make your condition worse. That also holds true with the McKenzie exercises that we described earlier. What we do find is that the exercises should be moderate in intensity, especially when we start looking at some of our endurance work, which we'll talk about later on. We want them to the point where they create sometimes an analgesic effect. And all that means is that basically by doing any kind of active program or active exercise, even if it is a specific program, just becoming more active and doing some light exercise, oftentimes will actually act like an analgesic. It's almost like taking an Advil or a Tylenol. It'll actually have your perception of pain will actually improve. So it's a very interesting thing. In addition to what we think they're getting it stronger, just the active exercise causes our brain not to register as much pain, and that's a very effective mode. So a lot of times I want people to do something, that is comfortable and doesn't set them back. A little discomfort while you're doing it that doesn't last too far after you're done doing the exercises. So we have mobilizations and manipulations. So there's different types of stretches that are specifically done on the spine. Some of them look like gentle stretches that you'll see that we'll have demonstrated in some photos here. Some of them are also what you think about as like chiropractic manipulations that they're doing like a high velocity thrust, like a very quick stretch to the spinal cord, with the idea that we're trying to create some of the called pain modulation and adjustment in pain, and also make us in the short term more comfortable, and also hopefully more apt to do more movement, because the big thing that we don't want is someone to be completely sedentary and not move at all. The idea is that we want to get a little bit of movement, and some of this has been shown to really help you get back to some, gentle movement quicker than just waiting it out. So that's one of the approaches. In the McKenzie method, we do use some mobilization and manipulations depending on the person and if it's appropriate. But this is a separate category. If you're not McKenzie trained, some practitioners will use this method to help you, and it really kind of, especially in the short term, seems to make a difference to get people moving a little bit faster. The last category is nerve gliding, and the idea is that we're basically moving our extremities, arms, or head in certain positions that causes the nerves, you see these large nerves right here that are exiting the spine, to move a little bit. Okay, and by moving it or causing gliding in the nerve, we cause a desensitization, and we prevent any kind of scar tissue or something that, let's say we have a trauma, and we have, with any trauma, we have inflammation, we have scar tissue. Sometimes that scar tissue, in theory, kind of gets around these nerves right here and compresses, kind of pinches them a little bit. And by undergoing certain nerve gliding exercises, it decreases the chance and kind of moves that nerve. So as we move my arm, the nerves coming off my neck will move a little bit. As I bring my leg out and I stretch my leg in certain positions, it'll actually cause the nerve to kind of move, and they call it flossing the nerve a little bit. And that can also be helpful, especially in the short term, as far as getting you more comfortable and moving a little bit better. Sometimes you need pain medication. You need some type of medication that actually helps you with the pain signal to your brain or to drop the inflammation. Those two approaches, one is for strictly pain, doesn't change inflammation, and then there's one for inflammation. So around these disc herniations, sometimes you have inflammation around that nerve root and that disc. And that is a source of pain. In fact, a lot of inflammation makes the nerves that go down to your leg, they can't conduct as well. They don't work as well when they're compressed by swelling in the area. Okay, so the theory is by taking an anti-inflammatory, or let's say if you did an epidural injection, which is like a steroid-based injection, or trying to drop down inflammation in the area, that actually can sometimes it can be a big help in the early stages if you need it. If you don't, I prefer you not to do it if you can tolerate it. But if you need it, especially if it's affecting your sleep, sometimes these pain medications are necessary in the short term. There's obviously a lot of talk about long-term, abuse of pain medication. So obviously we need to have a short-term. It's a short-term solution, not a long-term. But sometimes it's necessary. You need someone to get a little bit more comfortable. And sometimes they can't even engage in the core exercises or stretching exercise because they're in so much pain. So that'll allow them to become more mobile and more functional. And we really do want them to move. We don't want people shutting down. And sometimes when they're having that much pain, everything seems to hurt. So that's really where the place where pain medications can make a big difference. So this category, I would say activity modification, fancy word. Basically, we want to educate the patient about things that are kind of high risk, low risk. Explain really the stages of healing so people understand that sometimes in the early stages we want to get you moving, but we don't want to do certain things. A lot of times the patient intuitively knows that this bothers them and I have to stop this. So what we want to modify our activities in the short term, and eventually we slowly want to build up the resilience as you get better and start adding activities back to get back to what you want to do. Okay. Walk. If you hear me here at all, I talk to people about trying to walk as much as they can tolerate with any kind of disc problem. So walking in itself, it's an aerobic activity. It does cause that exercise-induced analgesia. It can actually help you with pain control just by walking. It really can make a big difference. And we'll talk about in another blog, a little more detail and video about the specific strategies for this. But really a walking program, I'll tell people, even if you can't do, I like to see 20 or 30 minutes a day. If that's too much for you, that's our goal. Okay, that's our goal, at least 3 times a week, 20, 30 minutes. 2 things happen. 1, we don't perceive the pain as much. Okay, we actually feel better. Okay, we're more upright, which is good. And the other thing too is they actually notice, especially with disc problems, it actually shows an increase of new cell activity in the area of the disc. So there's some belief that it actually helps with some regeneration of tissue in the area and can actually help with some healing in the area directly by doing this particular program. So walk. Some people can do it, like they'll have them do it. I call it the meal plan. Every time you eat, you walk. So we'll get people doing, 10 minutes in the morning, 10 minutes at lunch, 10 minutes in the evening. And the whole idea is just keeping a little activity through the day. And that's a general recommendation for lower back problems and disc herniations is we want to get moving a little bit. We like our ADD people that are moving and fidgeting and constantly changing position. We don't want someone shutting down, sitting, or even just standing excessively. You know, some people will utilize the standing desks, which are helpful, but what we want is we want a little sitting, a little standing, little crouching, we want to do a little bit of variety of movements throughout the day. What we don't want is to shut down and just sit, binge Netflix, and not move, or sit on our phone. That is the thing that we don't want. Okay, so keep that in mind, but the walking program is a good structure to that to help you get to the next stage. When I was trained in the McKenzie Method, one of the key things is that I was taught when I was trained was what's good pain and what's bad pain, and specifically the movement of pain. And the phenomenon that we use, or the guidance we give patients here in the clinic, and I use as well for my patients, I also talk about the phenomenon of centralization versus peripheralization. Okay, so the idea is, let's give you a scenario. I like this in more of a case study. Okay, let's say we have a disc herniation at the L5 S1 disc or L4 L5 disc. Okay, and it's hitting a nerve root. Okay, and the patient will come in and they'll say, "Hey, Tom, I have leg pain just on one side." Okay, the pain's running down and it's kind of down to right around the outside of my calf here. Okay, it's down my calf. It's there all the time. It's like a level 7 pain. Okay, so when we start doing an exercise, it could be a core exercise, it could be a walking program, it could be some of the McKenzie exercise we'll give out, the stretching. We'll say, okay, the pain is there. It's a level 7, let's say, or 6. It's right on the outside of your calf. Tell me if that pain becomes less intense there. Let's say we're doing a movement or a core exercise, or we're walking, or we're sitting. And we say, wow, I've been sitting for a while, and now that level 7 is becoming a level, let's say, 4 or 5, and it's actually reducing. That movement or activity is considered a positive direction. We're actually getting the movement up to further up the chain to where we think it's coming from the lumbar disc. Okay, so let's say we're doing an arch stretch or a cobra stretch. We're saying, wow, now it's no longer in my calf, it's in my mid-thigh, and it's actually more on the side of my hip. That's considered centralization. It's moving away, it's moving towards where we think it's coming from, the origin of the problem, the disc that's resting on the nerve, let's say. It's moving up. That's a good direction. So if we're doing a core exercise or strength, or let's say nerve gliding, whatever else, and it's moving up, that's considered a positive direction. Okay, so we use that as a rule. If you're noticing that positive direction, sometimes, which I've noticed in the clinic, is sometimes as it moves up, they'll say, wow, now it's out of the thigh, it's actually just in my central low back. Sometimes it's perceived that it actually feels worse. But as long as it's moving up, and even though it feels worse, I typically recommend people continue to do the stretches that we're recommending or strengthening, whatever the course may be, or the case may be. Now, in another scenario, let's say I started out, you started doing some stretches. Let's say we did a couple of McKenzie stretches or core exercises. And then we started when we were doing the core exercise and we had the pain just in the hip. We didn't have anything below that area. If that pain starts radiating further down, now it's not in the hip, it's actually now in my knee, back of my thigh, it's actually back in the calf or in my foot. That's called peripheralization. And that means it's going in the wrong direction. You're irritating that nerve somehow in the lower back by that herniation, and you're making it worse. So whatever movement or activity you're doing, you might want to modify the activity. If it's a stretch, you want to change the stretch or do a different version of it, or talk to your therapist, whatever the case may be. But that's called peripheralization. It's moving away. And that's direction 99.9% of the time I don't want to see. And I'll say, let's stop the exercise, let's change it, let's make take a different approach to that. So that's a phenomenon. We have a video on that as well. It explains in more detail, but it really helps out the patient when they're home. What do I do if I experience this? And also the practitioner, me, when I'm working with someone, I'll kind of talk to them and say, hey, what are you feeling? Where is it going? How's the pain acting? So we understand what's good and what's bad pain. So when is something more, let's say, when do we need to do more? We've tried exercise, we've tried, anti-inflammatories, we've done all these other things. What else can we do in a case of herniation? It's just not getting better, or we're getting uncomfortable, and especially if it's past that 3-month period, then we want to look at other options. Okay, and this is subjective. It depends on the person and what you're experiencing. This is the point where you're starting and considering epidural injections, which are steroid-based injections, which we talked about a little earlier, that drop the inflammation around that nerve root and sometimes can really make it function better, and you could feel a lot better from it. As long as we have the right area and you have a good doctor to kind of identify that area. Oftentimes you need an MRI to verify that, which you should have since you've already been diagnosed with a herniation. The other part is surgery. Surgery sometimes is very necessary. One of the most popular surgeries you'll see for disc herniations are microdiscectomies. And all that means is it's a very small incision. They go in there and they'll basically just shave it out and shave a portion of the disc that's resting on that nerve root, okay? But anytime we look at surgery in any body part, it could be a shoulder, it could be a knee, it could be whatever structure we're talking about, especially the spine in my experience, we can't unring the bell. And what that means is my mentor, Todd Edelson, talked about this, and I always remember that, is you can't unring the bell. Basically, something fundamentally changes in your body once you go in there with the scalpel and you manipulate it, you turn it. It might be the solution, but you really want to be careful that you exhaust all options, and also the option of time. Obviously, there's times when you need to take a more aggressive approach and you have to go into surgery much earlier. And those are considered some of the called the red flags. Then we'll explain that another time. But red flags are signs that we need to really address this problem quickly, much more quickly than allowing the passage of time. So consider that, but make sure you get a couple opinions if you decide to do that, the next step in that next surgery, to make sure it's appropriate for you. So now we're going to show you 3 exercises that you can do to take care of what we commonly give out in the clinic for people that have suspected or diagnosed lumbar disc herniations. And we're going to show these 3 stretches you can do. Basically, all these stretches you can do throughout the day, about 10 times every 2 hours. You're going to do these particular movements. And this can be very powerful in the early stages after you've started experiencing pain to kind of manage it and reduce your pain symptoms, whether you have leg pain because of disc herniation or central lower back pain. So here are the 3. Okay, so the first we're going to show you is just a simple what's called lumbar extensions and standing. So you want to have your feet maybe a little wider than your hips. I'm going to show you from a side view. You're going to place your hands on your hips. A lot of times when people have problems in the area like herniations, they'll have a little tightness in this direction. It's probably the most common direction. A lot of times they have pain going forward as well. But most times we address going backwards. So we place our hands on our hips. You can place it here or cup your hands. If it bothers your shoulder, you can put your hands at your side. But I'll show you the way I typically do it. So you're going to lean back, apply pressure, pressure on, pressure off. You want to get as far as you can until you feel like you're stopping. Pressure on, pressure off. You can do it 10 times every 2 hours, about 5 sessions a day. That varies. It should never make your condition feel worse. So, listen to the centralization, peripheralization. That helps guide you a little bit. And hopefully you start seeing that your motion starts improving in that direction. Okay, is always a good sign. And also the good sign that, oh wow, now I can go a little further, more comfortably going forward. So that's lumbar extension and standing. Okay, this is called a side glide and standing. Okay, you can do this against a wall, or you can do it in free like I'm doing here. Most times, this is for people that just have, let's say, pain on one side, especially on one side of the back or one leg. Typically, it doesn't work with people that have symptoms on both legs at the same time. So most times, the painful side right here is the one that we're pushing on. Okay, so if I'm standing like so, we want to apply pressure to my side, and we want to go in this direction, so we're pushing this way. So pressure on, pressure off. You slowly want to work into it. If you have someone that's a little bit tilted like this, same idea. You want to push on this side. Most times they have symptoms on this side, and you want to get to midline and you want to cross. Okay, you don't have to have that change, but you'll see people walk in the clinic like this. We're pushing on the side where the hips are going away. If you don't, you just have leg pain down one side, that's fine. So pressure on, pressure off. Same idea, 10 times every 2 hours, about 5 sessions a day. I hope to see changes in like 3 to 5 days. Some people respond very quickly. Most times people need a few more repetitions. Next one is a prone press up. Some people refer to it as a cobra in yoga. So you want your feet a little bit astride. You want your hands kind of in front of your shoulders. You want to push up. You want to really use your arms to create this motion. You don't want to lift your back using your back muscles. So you want to push up as high as you can. You may find you can only go this far at the start and then back down. So all the way up, 1 or 2 seconds. Make sure you can relax. And back. And as you do it over the course of 10 times every 2 hours, you may notice you start going further and further, okay? And everyone's range of motion is slightly different, so some people actually have to use like a bolster or a little roll here so they can get a little bit more range of motion, so their arms are higher and they're pushing up a little higher as they go, okay? But you got to get to the very end of motion as you do this exercise, okay? Best of luck. 10 times every 2 hours, about 5 sessions a day. I know this was a long one, but there's a lot of information I wanted to cover for people that have disc problems. If you got a lot out of this, give us a thumbs up. We'd love to hear that. If you want to hear more about various types of natural ways of healing, whether it be disc herniations or rotator cuff problems or meniscal tears in your knee, please subscribe to our channel. You get notifications like this. And put a comment in there. We'd love to hear from you if you've tried any of these approaches or you have any other questions that maybe we didn't cover in the video that you have concerns about. I try and address all the comments I can, but I can't get to them all. All right? And especially like it or share it with friends if you have someone in need that's had this diagnosis. All right? Have a great day.